Okay, so I guess that you can see the screen now. Okay, so again, I'd like to welcome you all to this new session of our course. We are going to discuss the cornea and external diseases, and by meaning that the external diseases, we mean the ocular surface diseases and conjunctival diseases. So through this lecture and the next lecture, we are going to cover the cornea, the conjunctival diseases, the dry eye, the scleral diseases, and also we will go through the corneal surgery. So let's start first. So this will be the spectrum of our these two lectures that we are going to discuss: the conjunctival disease, corneal disease, scleral disease, and surgery. Let's jump immediately into the first section of our course, which is the conjunctival disease. Conjunctival disorders tend to be easy questions in the exam, no lots of investigations and no complicated management. Mostly they are self-limited, so these will be like easy questions for the exam. Before we discuss the conjunctival disorders, we need to understand two major or two different pathological entities, which will be helpful to make a differential diagnosis of a conjunctival diseases. These are the papillary conjunctivitis and follicular conjunctivitis. So if you try to check the conjunctival disorders, you mostly will find that it will cause one of these. Can cause papillary conjunctivitis, such as giant papillary conjunctivitis caused by the contact lens or by foreign body, or it can cause a follicular conjunctivitis, such as the adenoviral keratoconjunctivitis, or sometimes it can cause both mixed papillary and follicular conjunctivitis, such as in cases of trachoma. So this will be an important clue for diagnosis. So we need to know how to differentiate between a papilla and the follicle. So starting from the papilla, what is a papilla? It consists of hyperplastic conjunctival tissue full of inflammatory cells. They are seen in the palpebral conjunctiva, and usually they occur with bacterial and allergic conjunctivitis. So you can see here, these can sometimes be small like that with central vascular tuft. So you see this pinpoint red heads, these are central vascular tufts. They will also show epithelial hypertrophy. They will show proliferation, hyperplasia of vascular stroma. So this is basically a stroma, a vascular stroma. So there will be blood vessel, and there will be some inflammatory cells causing this appearance of papillae. These papillae can range in size from small to medium size to giant papillae. And by giant papillae, we mean a papillae which is larger than 1 millimeter. So these are considered a giant papillae of more than 1 millimeter. On the other hand, the follicles consist of hyperplastic lymphoid tissue. So it is not a vascular tissue, it is a lymphoid tissue, and appears as elevated lesions encircled by blood vessels. So these are basically made from lymphocytes. It is lymphocytes surrounded by conjunctival blood vessels, okay? And they are seen in reaction to topical agents, as we are going to see what's called toxicity or toxic medicamentosa, or adenoviral keratoconjunctivitis, or chlamydial conjunctivitis. So these are some causes of follicle. So follicle appears as not reddish with reddish head like that in papillae, but looks more like grayish white elevations with a vascular center. This is very important. Here the center is vascular, here is the center is avascular. Okay. And it is because it is that's why it is when the follicles are not very prominent or doesn't develop in neonatal conjunctivitis in the first 2 or 3 months, because the immunological system is not still well developed. So as I told you, it is a hyperplasia of lymphoid tissue. If the lymphoid tissue is not well developed, as in neonates, they will not occur. So if that child or if a neonate present with a disease that will cause follicular conjunctivitis, you may not find the follicles very well prominent. Okay, so this will be our differential. So now we are going to discuss what are the diseases that will cause papillary conjunctivitis and the diseases that will cause follicular conjunctivitis. Starting by papillary conjunctivitis. So we will cover the allergic conjunctivitis and bacterial conjunctivitis and infectious conjunctivitis. So starting by the allergic, first disease is called the acute allergic conjunctivitis. What is the acute allergic conjunctivitis? It is a very self-limited condition, occurs due to exposure to allergen like pollen, sometimes like an insect bite. This will lead to massive or severe conjunctival inflammation or reaction to this allergen. So as I told you, it is mostly due to pollen. So you may expect when does it occur or the incidence. It will be more in the spring and summer when there is more. This is the season of the pollens, and more common to occur in young children. The clinical picture of the acute allergic conjunctivitis is the hallmark of this inflammation is the severe or massive conjunctival chemosis or conjunctival swelling. You can see that conjunctival is hugely swollen, and also it's characterized by redness, watering, itching, and lid edema. All these are criteria for acute allergic conjunctivitis. This is a very self-limited condition. No investigations are needed, and the treatment is just by cold compresses or some topical antihistaminics or topical anti-inflammatory drugs. Just maybe for a few days or even a single drop will be enough to control this condition, as it is not very severe or it is not very prolonged in course. So this will be our first disease, which is acute allergic conjunctivitis. The next one, which will be more or less similar to it, will be called the seasonal and the perennial conjunctivitis. So what will be the difference between the seasonal and the perennial conjunctivitis? Let's classify them and know what is the incidence of each one of them. So the seasonal, it is more common than the perennial, while the seasonal, it's more common and more worse in the spring and summer, while in the perennial, they will be more worse in winter. However, they can occur at any time during the year. Also, they are both different in the type of allergens. As in seasonal, which is more common in spring and summer, the allergens will be some trees and the grass pollens. On the other hand, the perennial will be more common, the allergens to be more commonly causing the perennial, the conjunctivitis will be the house dust mites, the animal dander, and the fungal allergens. So this will be just a difference in what is the etiological factor or the risk factor and what is the season. But in the clinical picture, both are the same. Both can cause a transient, acute, or subacute redness, watering, itching, conjunctival hyperemia, mild papillary conjunctivitis, chemosis again, and lid edema. Also, sometimes it is referred to as seasonal or perennial rhinoconjunctivitis, as it will cause the rhinorrhea as well. So you see, it is the same manifestations of all allergic conjunctivitis: redness, watering, itching, conjunctival hyperemia, mild papillary conjunctivitis, chemosis, and lid edema. Again, no investigations are needed, and the treatment is to just control the symptoms. So those patients can be managed by artificial tears, mast cell stabilizers. So what is the role of mast cell stabilizers, such as sodium chromoglycate? They will just stabilize the mast cells. Mast cells is one of the inflammatory cells that, or the acute inflammation cells that will release inflammatory mediators such as histamine. So by giving the drugs that will stabilize these mast cells, they prevent their degranulation. So they will keep the inflammatory mediators such as histamine within the mast cells themselves. Also, these patients, if they have already degranulation of mast cells and they have allergic manifestations, they can receive topical antihistaminics 2 times per day, non-steroidal anti-inflammatory drugs, topical steroids, and oral antihistaminics. So does this mean that we should give all these drugs to all the patients? No. Actually, we tailor our treatment depending on the case. So for mild cases, only topical medications such as topical antihistaminics and the muscle stabilizer or combination between both will be enough. For more severe cases, we can add non-steroidal anti-inflammatory topical steroids for very severe cases. So for all allergic conjunctivitis, that you will find that the lines of management will be almost the same, but the difference is that these diseases differ in severity. So we give the treatment which is more suitable to the grade or the severity of the case. Okay, so those two diseases are common in practice, but not common in the exams, because you can see that it is already self-limited. So what are the common diseases in practice and in the exam as well? Let's start by the first one, which is also within the spectrum of allergic conjunctival disease, which is the vernal keratoconjunctivitis. So what is the vernal keratoconjunctivitis? As the name, let's first analyze the name vernal, so it may be related to the season of the spring, as sometimes it's called as a spring catarrh. This is the other name of this disease, spring catarrh. So those patients will have history of atopy, eczema, hay fever, asthma. So those patients are already pre-sensitized. Those patients have already other allergic manifestations such as atopy, eczema, hay fever, and asthma. Also, they could have family history. So that is very important to ask those patients about the other systemic associations or the presence of family history. So is it a disease of young age or old age? Well, it is a disease of young age, as the more commonly affected are males more than females. But as the children or the young females or males getting older, the difference in age will be, the difference in the incidence will become less. So it is more common in males than females, especially in the younger age group. Typically, it affects the age of onset. It starts from 10 to 12 years old, but this is not the case always. Let me tell you something. If the exam tell you that the vernal keratoconjunctivitis always occurs in between the first or second decade, or in the between 10 to 12 years old, there are few case reports of about 5 months old. A newborn of like 5 months old develop vernal keratoconjunctivitis. However, most patients are between 5 to 25 years old, and the good thing is that this disease has a good prognosis that most patients will resolve at puberty. Till the puberty or till the disease will resolve as a natural course, we need to control the symptoms when it comes or when the patient has exacerbation of symptoms, and also to prevent a very common association to the vernal keratoconjunctivitis, which is keratoconus, as those patients will have a continuous rubbing of their eyes and they will experience continuous itching. So this continuous rubbing will cause weakness of the stromal collagen of the cornea. So it is very important to instruct those patients to prevent the eye itching, to guard against keratoconus. Okay, so let's get started with the clinical picture. So how do these patients present? Those patients will present with affection not only for the conjunctiva, but for the lids and the cornea as well. So the eyelid affection is not very common, but it can occur that the lids become eczematous, some excoriation at the outer canthus, some reactive ptosis. But this is not as common, or the eyelid affection is not as common as the next disease that we are going to discuss, which is the atopic keratoconjunctivitis. The most important features are within the conjunctiva itself. So we can classify the conjunctival disease into the disease that affect the palpebral conjunctiva and the disease that will affect the limbal conjunctiva. So for the palpebral conjunctivitis, it is more common to be superior than inferior. Again, it is more common to be superior, and it will present with papillary conjunctivitis. Sometimes it can present with giant papillae more than 1 millimeter in diameter, which will be giving this characteristic pattern of cobblestone. This is very famous picture in the exams, where they present you a picture of cobblestone papillae and asks you many questions about the vernal keratoconjunctivitis. So don't forget this picture. Also, you can see the mucus deposition in between these giant papillae. These giant papillae will have some implications and some consequences on the cornea, as we are going to see right now. Also, the vernal keratoconjunctivitis is one of the diseases that can result in pseudomembranous formation, also can happen due to palpebral vernal keratoconjunctivitis. It is not a true membrane, as it can be separated easily from the cornea, from the palpebral conjunctiva. If the disease affecting the bulbar conjunctiva, it will result in limbal vernal keratoconjunctivitis, which has a very characteristic feature of what is called Horner Taranta dots. These are Horner Taranta dots. So there are limbal follicles. This is in the disease, when it affects the limbus, it will cause some limbal follicles. These limbal follicles will show white dots. These dots are aggregations of eosinophils and epithelial cells present at the apex of these limbal papillae. This is very important and very commonly asked in the exams, which is the contents of these white Horner Taranta dots. So remember, two things here asked in the exams. The white Horner Taranta dots occur in what disease? Occurs in vernal keratoconjunctivitis. What are the contents? The contents are eosinophils. Okay. So these are the eyelid and conjunctival affection of the vernal keratoconjunctivitis. What about the corneal affection? We said it is kerato. So all these diseases we are discussing, it will cause both conjunctival inflammation and corneal inflammation. So you can see first, before going to the cornea, you can see the appearance of these limbal follicles on both eyes, very characteristic. And when you see it whitish, and you see it elevated, and you see it with conjunctival redness, this means that these limbal follicles are active, so you will need some treatment. Regarding the keratopathy, so usually almost all the keratoconjunctivitis conditions start by some epithelial erosions, punctated epithelial erosions in the superior and the central cornea. Then later on, there will be confluence of these erosions, so that they will result in macroerosion. Macroerosion means that the epithelium at this area is weak, so both of these epithelial erosions are sloughed, leading to large ulcer, macroerosion. Another very important questions in the exams regarding the vernal keratoconjunctivitis is the next sign. The next sign is the vernal plaque or shield ulcer. So you can see that this is an ulcer, corneal ulcer, and this ulcer is in the superior cornea. And what is the cause of this ulcer? And is it an infective ulcer? No, it is just a mechanical ulcer. It is caused by the rubbing of giant papillae against the cornea. So the giant papillae will rub against the cornea, leading to sloughing of the epithelium. And sometimes there will be accumulation or deposition of calcium and mucus on the Bowman's layer, so it will cause this plaque. So it's sometimes, if this is called shield ulcer, and this is the vernal plaque. Both are manifestations of vernal keratoconjunctivitis. And this will be a problem that this plaque will prevent the reepithelialization. That's why if it happens, we need to debride it. Eventually, if the disease is not controlled by medications, it will result in subepithelial scarring or corneal scarring. Okay, so this is what we need to prevent by controlling the vernal keratoconjunctivitis in those young children. as the norm of the conjunctival disease, usually no investigations are needed. However, if you do analysis of the tears, you will find that there is high histamine and immunoglobulin E, which indicates that those patients have underlying allergic process. And the only investigations you may need for those patients is to do corneal topography. If the child is older enough and can sit on the pentacam or any corneal topographer, and you want to make sure that those children are not developing keratoconus, especially if they are developing high astigmatism or progressive astigmatism. So you need to do corneal topography for those patients, because if there is any sign of keratoconus, this will be an indication for immediate interference, because keratoconus, if it happens in children, it progresses very rapidly. For the treatment, again, it will be the anti-allergic treatment. But we start first by controlling the risk factors, as this disease is meaning that the child is sensitized to the allergens that may not be causing any problem to other people. So we need to first do the prevention, to control the risk factors, to avoid allergens as much as possible. Then to control the inflammation by cold compresses, mast cell stabilizers, topical antihistaminics or combinations, non-steroidal anti-inflammatory, topical steroids for severe cases, especially in the exacerbation, so they can receive short-term course of topical steroids. They also receive oral antihistaminics, topical acetylcysteine. This will be helpful for the mucus plaque formation. And they can also, for cases which are not responsive or severe cases, they may receive local steroid injection, such as supratarsal injection within if the disease is in the palpebral conjunctiva, or in the bulbar conjunctiva, so they can receive subconjunctival injection, perilimbal injection around the limbal follicles in case of bulbar disease. Another mode of treatment, which was, well, actually it was previously used, but it recently received the FDA approval, is the cyclosporin A. So cyclosporin A was used earlier in the treatment of vernal keratoconjunctivitis, but the FDA approved this disease, I think this year or the last year, at the dose of 0.1%. So cyclosporin as an immunosuppressive can be given for those children in a dose of 0.1%, which is almost double the dose we use for the corneal patients or for the corneal diseases. Like for cornea, we use it in the concentration of 0.05%. Also, tacrolimus eye ointment can be used by the same mechanism, that it will be immune suppressive. So for this disease, which has an underlying immune process, they will be helpful to control the immune process and to relieve the inflammation. For the vernal plaque, we do debridement. So we remove this plaque to allow the epithelium to heal, or if there is causing superficial scar, especially if it is visually significant, we do superficial keratectomy. Okay. Dr. Islam, surgical treatment for resistant giant papillae? No, we don't. The papillae are not, it is a reaction, but it is not like a tissue oil. It is not like a plaque that you are going to remove, but if you remove it will cause just a scarring. So you treat by you just increase the frequency, the dose, the type of drug, the anti-inflammatory drug that you are using, but you don't interfere surgically in these cases. The only surgical interference here will be like supratarsal injection of a steroid. That's it. Okay, hope that is clear. Let's now check for the next topic, which is closely similar to the vernal keratoconjunctivitis, but with some differences. This disease is called the atopic keratoconjunctivitis, or AKC. So there are some annotations. Let me clear all this drawing. Okay, so what is the atopic keratoconjunctivitis? It is another disease associated with atopy. So those patients will have also a family history of atopy, family history of asthma, eczema, hay fever. So they can have atopic disease in one of or more parents, characterized by periocular itching with atopic dermatitis. So this atopic dermatitis is more common in atopic keratoconjunctivitis. So as I'm going to discuss, I'm going to tell you what are the differences between atopic keratoconjunctivitis and the vernal keratoconjunctivitis so that you will spot these differences in the exam. First of all, the atopic dermatitis is more common in the atopic keratoconjunctivitis than the vernal disease. They will also have a history of seasonal or exposure-related exacerbation for those patients. Incidence, it is rare. It's bilateral. This is a disease of bilateral. And the most important here is the age of onset. This is a disease of adulthood, not a childhood like vernal disease. It developed at between the age of 30 to 50 years. Again, this is a disease of adulthood. However, there will be like 5% of those patients will have history of vernal keratoconjunctivitis, but they develop the atopic disease in the adulthood. Hope that this is clear. So what will be the clinical picture? As we see, it will also affect the eyelid, the palpebral disease, and limbal disease. For the eyelid, it is more common to be affected in the atopic than the vernal. It will be characterized by periocular and lid dermatitis. So here is the skin is very massively affected because this atopy, it is called atopic keratoconjunctivitis, and the atopy will affect the skin more. So it will cause loss of cilia. You see here, this patient, loss of cilia. There is no eyelashes. There is mebomonitis. There is keratinization and punctal ectropion. So this disease is very a severe disease that will affect the eyelids. And this will give you a clue that those patients may even need more aggressive treatment than those patients with vernal keratoconjunctivitis. So remember that I told you that the scale of treatment, we are going to get to that later. So for the eyelid, there will be eyelid maceration, there will be mebomonitis, keratinization, ectropion of the puncti, and dermatitis. For the palpebral disease, it is more to be inferior, unlike the palpebral disease or unlike the vernal disease. Palpebral disease here is more inferior. So if there is follicles, if there's papillae, they will become more there will be papillae, not follicles. It will be more inferior. This patients or those patients characterized by what? You can see papillary reaction. However, this papillary reaction may not be very evident because of the pale white edema. This lid, sometimes they are call it a featureless lid. There is no features. There are diffuse pale edema. So you see that it doesn't show any features. Again, it's called featureless eyelid with pale white edema. Sometimes it can be present with fibrosis. And as it affects the inferior more, it can cause some inferior fornix shortening. It can also cause symblepharon or adhesion between the bulbar and palpebral conjunctiva. This is the symblepharon. This is for the limbal diseases or for the palpebral diseases. For the limbal diseases, there will be perilimbal gelatinous hypertrophy. It will be similar to that of Horner-Taranta dots or the limbal follicles that happens in the vernal disease. And sometimes it can present with Horner-Taranta dots, but not very common like in the vernal disease. So Horner-Taranta dots more common in the vernal, but it can occur in the atopic. Eyelid affection more common in the atopic, but it can happen in the vernal. Okay. So these are for the conjunctival and lid affection. What about the corneal affection? For the keratopathy, again, as we mentioned, it will usually start by punctured epithelial erosion. Then it proceeds to persistent epithelial defects, and it will cause subepithelial scarring, even more rapid than the vernal disease, and also peripheral neovascularization. So these are the signs of corneal affection that happens in the atopic keratoconjunctivitis. So how would we investigate? You will not need it, as we mentioned, but again, we can do corneal topography if the clinical signs of keratoconus is present, as we are going to discuss later on, and treatment by controlling the risk factors such as environmental irritants that we mentioned, and to control the inflammation. First of all, correction of lid problems, like those patients could have cicatrization of the lid, and with this will result in entropion trichiasis with the eyelashes rubbing against the cornea. So this will add to keratopathy that these patients are suffering from. We need to treat that. We need to treat any entropion, trichiasis, distichiasis. If you are not sure about what does these terms mean, wait for the oculoplastics lecture. We are going to cover all these. Also, they should be treated by the usual anti-allergic drugs such as mast cell stabilizers, topical antihistaminics, non-steroidal anti-inflammatory drugs, topical steroids, oral antihistaminics, topical acetylcysteine, topical local steroid injection, cyclosporin A, tacrolimus, and systemic immunosuppressives. Those patients are more likely to need systemic immunosuppressives than the vernal disease, as those patients will have more severe inflammation, more aggressive inflammation, so more likely to need this systemic immunosuppressive. Okay, hope that this is clear. Okay, for giant papillary conjunctivitis, or the next disease is a giant papillary conjunctivitis or mechanical conjunctivitis or GPC. For what will be the reason or the cause of giant papillary conjunctivitis? As you can see, it's called sometimes mechanical. So it is a mechanical response or a response from the conjunctiva due to mechanical irritations. So there is sometimes a foreign body that will cause mechanical irritation to the conjunctiva. What are these causes, or what are the causes of mechanical irritation? It will be the allergy to foreign body, such as contact lens. Those patients who are contact lens wearer can develop conjunctival irritation and papillary conjunctivitis. Also, exposed stitch. So if a patient has like any exposed stitch after extracapsular cataract surgery, so this will cause rubbing of this stitch against the conjunctiva, leading to irritation. Ocular prosthesis, especially if the patient is not treating it with very good hygiene, this can result in conjunctivitis. Scleral buckle as well can rub against the conjunctiva, leading to irritation. So what will be the clinical picture? Those patients will have foreign body sensation, redness, itching, increased mucus production, contact lens intolerance. And when you check the signs, what will be the signs? You can find the presence of giant papillae. It is called giant papillary conjunctivitis for a reason. So it will cause giant papillae more than 1 millimeter. And also it can cause some proteinaceous deposits. So under the contact lens, so if you remove the contact lens, you will find some proteinaceous deposits. You will also find some excessive contact lens mobility, giant papillae, keratopathy, sometimes, which is rare actually. It can cause, but it is rare. And sometimes the ptosis may occur from the weight of the eyelid. Again, no investigations are needed. We just jump to treatment. So treatment is by control the risk factors, remove the cause. So those patients needed to know how to do effective cleaning of the contact lens or prosthesis to prevent any deposits on it or any to prevent infection of them. So you will need to just may need to stop the contact lens for some time or for longer duration. Need to know how to use it, need to know how to clean it, especially the contact lens or prosthesis. And till that happen, or till we need to control the manifestations by mast cell stabilizers, topical antihistaminics, non-steroidal anti-inflammatory drugs, and topical steroids. So this will be the same anti-inflammatory or anti-allergic medications. Okay, easy. Dr. Islam is saying, what is the mechanism of cyclosporin? Well, a cyclosporin is an immunomodulatory agent or immunomodulatory drugs. So it will cause what's called inhibition of production of cytokines. So these cytokines are involved in the regulation of T cells activation. So this will be the main mechanism. It is an immunomodulator. Okay, so let's now move to the infectious keratoconjunctivitis. And by the infectious, we start by the adenoviral. So the first three, which is the allergic conjunctivitis caused by the vernal disease or the atopy or the giant papillary conjunctivitis, these will cause papillary conjunctivitis. But now we will discuss the follicular conjunctivitis. What are the diseases that will cause follicular conjunctivitis? Started by the infectious. So we have three viral drugs: the adenovirus, the herpes, and the poxvirus. Again, the adenovirus, the herpes, and the poxvirus. So what will be the adenoviral keratoconjunctivitis? What are the manifestations? Let's now see the whole story of the adenovirus. Very important and asked in the exams is the type of the virus. So they ask you if it is single-stranded, double-stranded, DNA, RNA. Please focus on this little thing that you may miss if you are reading alone. So it is a double-stranded DNA virus. The incidence is very highly contagious. Like it spreads in epidemics, affecting the overcrowded locations, like in hospitals, like in schools, like in swimming pools, and also it will be transmitted easily from one person to other by contact of respiratory secretions or ocular secretions. So it is very contagious. So what will be the clinical picture? The clinical picture depends mainly on the serotypes. So the adenoviral keratoconjunctivitis has two main groups of serotypes. So it will cause follicular conjunctivitis, and there are serotype caused what is called epidemic keratoconjunctivitis. Serotypes 8, 19, 37, 8, 19, 37. So it will be how to, so you can remember it by like, you can consider like 8 plus 19 plus 19, it will equal 27, but you can make it like 37. And the other serotypes called the pharyngeal conjunctival fever, it is 3 and 7. The serotypes are important. So we have two important serotypes in this lectures: the serotypes of adenoviral keratoconjunctivitis and the serotypes of chlamydia. Both are important and asked in the exams. Okay, so regarding the epidemic keratoconjunctivitis, so it will be, as I told you, it's called by serotypes 8, 9, 8, and 19, and 37. Those patients usually will have low systemic manifestations. So it will be having mainly an ocular affection. So like those patients, 80% of those patients will develop keratitis. This is a very serious incidence or very serious association. So it is very important for those patients to follow up very closely to prevent a serious visual or permanent visual impairment because of this keratitis. Also, it's characterized by preauricular lymphadenopathy, as any viral infection, pseudomembranous formation, and sometimes subconjunctival hemorrhage in severe cases like this case. So again, we're present with follicular conjunctivitis, decreased systemic symptoms and increasing keratitis symptoms or more keratitis like in 80%, pseudomembranous formation, and subconjunctival hemorrhage. For the pharyngeal conjunctival fever, it is between or serotypes 3 and 7, it will have more incidence of systemic problems. These systemic problems will be fever and pharyngitis, as the name implies, pharyngoconjunctival fever. So pharyngitis and fever. And the name of the first series is epidemic keratoconjunctivitis. So as the name implies, it is more commonly to cause keratitis. Okay, back to the pharyngoconjunctival fever, serotypes 3, 7. It will cause more systemic problems like pharyngitis and or respiratory tract affection and feverish. And luckily for the cornea, it will cause less corneal affection or less keratitis, about 30%. So what about the keratopathy? So how is the keratopathy manifest? It will present, starting by some transient focal epithelial keratitis like that. So then later on, it will develop subepithelial infiltrates. So it will be multiple, punctate, spread all over the cornea, subepithelial infiltrates. This is one of the differential diagnoses of subepithelial infiltrates that we are going to discuss later on in the cornea. Okay, so it may persist for months and sometimes it can cause some visual degradation. So for those patients, we don't need investigations, but if we are in doubt of the cause, or if in severe cases like subconjunctival hemorrhage associated with adenoviral, we can isolate the virus by different methods, which will be for any virus, almost for any virus, like InGEMSA stain, PCR for virus amplification, viral culture, and serology. So these are the investigations for adenovirus. They were asked once in the advanced ICU exams. Just don't remember if it was advanced 180 or 115, but it was asked before in the advanced ICU. For the treatment, actually, the spontaneous resolution is the rule for adenoviral. So usually it takes like around 2 or 3 weeks, and it will spontaneously resolve as most of viral infections. And it was found that no effective antiviral medications can be administered in these cases. All we need is to just reduce the transmission of infection. So avoid contact, avoid like sharing towels between the students or between the same house parents or children living in the same house. Try to isolate, try to any infected patient should use his own instruments, own tools to prevent the transmission, as it is highly contagious. And those patients can only receive topical steroids for severe membranous adenoviral infection or to prevent the development of severe keratitis. So the topical steroids can be employed here. Okay, so this will be the, yes, for the subepithelial infiltrate. Even for those patients when after even resolution of the viral infection, and when we see them later on, there is no acute infection or so, but they only have residual subepithelial infiltrates. So the treatment for those patients, they can continue on weak steroids such as fluoromethanolone for like few months or up to 1 year for gradual, very slow resolution of these subepithelial infiltrates. So this will be the treatment for those patients who are having persistent subepithelial infiltrates even after the resolving of the acute attack. So you see, our main aim in the adenoviral keratoconjunctivitis is to control or to manage the corneal affection. Okay, the next viral infection which will cause follicular conjunctivitis is called the molluscum contagiosum, or the condition itself is called the molluscum contagiosum. So what is the causative organism? It is called the poxvirus. And poxvirus is again a double-stranded DNA virus. So what will be the incidence of this poxvirus, or who are more prone to develop this disease? It is more common in children, so it has peak incidence of between 2 to 4 years old, and it is transmitted by contact, and usually the child is healthy. So mostly those children are healthy, but if they are unhealthy, we should consider another possibility that I'm going to tell you right now. What will be the clinical picture of those patients? The eyelid will present with this lesion. It is usually single lesion. It is a pale, waxy, umbilicated nodule. You see, it is a single lesion, pale, waxy, and it's slightly elevated, and it has a central umbilicus. This is very characteristic lesion and very characteristic shape. And this will be very essential, and also we are going to discuss it in the pathology. It has a very certain pathological features. This disease or this follicle, when this follicle or this mass is shedding the virus into the palpebral conjunctiva, it will result in the follicular conjunctivitis. So basically, the follicular conjunctivitis is a reaction to shedding of the virus from this nodule into the fornix. Okay. When this lesion is multiple, this is the question which also appears frequently in the exam. What do you think if the patient has multiple mollusca like that? Consider HIV. Consider immune suppression. Immune suppression, one of the features of immune suppression is the presence of multiple mollusca affection. Again, this is a clinical diagnosis, no need for investigations, and for the treatment, those patients should be treated by just simple expression. Just expression of these masses to evacuate it, to empty it from the contents inside to decrease the viral load. Okay, so the third viral cause of follicular conjunctivitis is the herpes simplex virus. Again, what is the cause of the virus, or what is the type of the virus? It is a herpes simplex type 1 virus. So herpes simplex type 1, remember when we talked about the ophthalmia neonatorum, what was the cause of the ophthalmia neonatorum by herpes infection? It was the herpes simplex type 2. So herpes simplex type 2 will cause infections below the waist, while herpes type 1 will cause infection above the waist. So it will be double-stranded DNA virus. It will, the incidence, it is more commonly to be unilateral and more common in children, as we are talking about the primary herpes infection. Primary herpes infection is the first exposure to herpes infection in life. So it is a disease of childhood. Clinical picture, how does this lesions present? Those patients present with what's called blepharoconjunctivitis and keratitis. So there is blepharitis, conjunctivitis, and keratitis. Again, I'm speaking about the primary infection, which occurs in the childhood. Those children will present with lid vesicles like that. These are lid vesicles caused by the herpes, and they will have follicular conjunctivitis. Also, they can develop keratitis. So our aim in this patients is to prevent the keratitis or to manage the keratitis if it happens. Okay, so those patients present with blepharitis, follicular conjunctivitis, skin vesicles, keratitis, and preauricular lymphadenopathy. Investigations are usually not needed. This is a clinical diagnosis, but again, we can do gem sustain, PCR, viral culture, serology, and the treatment by the antiviral medications, depending on whether the cornea is affected or not. So usually those patients can be managed by the dermatologist for the skin affection, and by just topical antiviral, skin antiviral, and skin antibiotics. And for the cornea, we do topical antiviral medications, as we are going to discuss in the cornea. So this will be the third cause of the follicular conjunctivitis, and this is the third viral reason. So what are other organisms than the viruses that will cause follicular conjunctivitis? The Chlamydia trachomatis. So what will be the spectrum of Chlamydia trachomatis? So the Chlamydia trachomatis can cause two main diseases which will be of ophthalmologist interest. The trachoma caused by chlamydia trachomatis serotypes A and B and C. Remember, I told you there are some serotypes which are important. One of them is the chlamydia trachomatis, serotypes A and B and C. So what is the incidence? Is that trachoma is a disease of the developing world or the developed world? Well, the trachoma is a disease of the developing world. Actually, it is the leading cause of irreversible, preventable blindness in the developing world. So actually, this could have been prevented in the developing countries, and this is what is the rule of WHO to provide health surveillance and health campaign for poor countries to manage trachoma. As I'm going to tell you now, actually the cause of blindness not is secondary to the conjunctival disease, not the conjunctivitis itself will cause blindness, but it will be secondary to cicatrization that affect the conjunctiva and the eyelid. So those patients are mainly, or the trachoma become more endemic in countries where there is overcrowding, there is poverty and poor hygiene. This is where the chlamydia trachomatis will become more prevalent. The clinical picture, well, we need to understand an important concept that though there are patients who have active trachoma, that those patients will benefit from the antibiotic therapy. And patients with chronic or cicatrizing trachoma, those patients, we don't give them a antibiotic for chlamydia trachomatis. Those patients just developed the complications, so we need to manage the complications. So if a patient with active trachoma, they will have mixed papillary and follicular conjunctivitis, mucopurulent discharge, and sometimes they will show superior epithelial keratitis and pannus formation like that. Pannus will take some time, but the main manifestations for active trachoma will be acute papillary and follicular conjunctivitis and mucopurulent discharge. So this means that these patients could have acute follicular conjunctivitis caused by trachoma. If the patient was treated and the disease recurred, or if the patient was not treated, he will develop the cicatrizing trachoma. So the cicatrizing trachoma, it is where the disease will show its complications. What are these complications? It is cicatrizations. Cicatrizations meaning a scar. Scarring affecting the conjunctiva, affecting the eyelid, affecting the cornea. So how does this manifest? Or how does the cicatrizing trachoma manifest? It manifests by usually involving the superior conjunctiva. This is again very important. The trachoma mainly involved with the superior conjunctiva. In the conjunctiva, when you flip the lid, you will find the conjunctival scarring, sometimes referred to as Ehrlich's line. Ehrlich's line. Also, it can present with superior limbal follicles, but these are not the same like the vernal follicles or the limbal follicles of the vernal keratoconjunctivitis disease. They will resolve to show these shallow depressions. This is called Herpet's pits. Herpet's pits are shallow depression in the side of trachoma or present at the limbus, which will indicate the presence of previous limbal follicles due to trachoma. This is a very common question in the exam. Very, very, very common to differentiate between the Herpet's pits and the Horner Taranta dots. So they keep asking you where does it occur? The Herpet's pits in trachoma, the Horner Taranta dots in the vernal disease. So they just want to confuse you because both are follicles or pits, and both are present at the limbus. So just for you to know what is the difference or how to differentiate that in the trachoma, it is like a depression. It's a pit called Herpet's pit. So you will find a depression in the limbus, and it is more yellowish in color or brownish in color. But in the vernal disease, it is an elevation. It is more like a follicle or nodule. It will be more whitish in color. So this will be like the affection of the bulbar conjunctiva and palpebral conjunctiva, causing these manifestations of scarring. For the eyelid, it will cause what's called trichiasis, dystichiasis, cicatricial entropion. So these are the main problems in the lid. The lid will show rolling in of the lid margin, entropion. There will be mal-directed lashes or trichiasis. There will be extra row of lashes or dystichiasis, resulting in that these will rub against the cornea. These eyelashes will rub against the cornea, causing corneal neovascularization and opacification. And this will be the cause of blindness in those patients. Remember, I told you. And then those patients have, this is the disease will be the commonest cause of irreversible blindness in the developing world. This will be the reason. That's why those health campaigns managed by the WHO will do lid surgeries for those patients, lid surgeries in order to correct this lid malposition, in order to prevent rubbing of the eyelashes against the cornea and subsequently the corneal opacification and the blindness. Investigations, again, rarely used, but enzyme immunoassay can be used to diagnose trachoma, but again, it is a clinical diagnosis. For the treatment, we need to, the WHO adopted a specific strategy called the SAFE strategy. It's also asked in the exams. SAFE strategy is every letter will count for a specific strategy. So S for surgery for trichiasis. We will discuss the surgery for trichiasis and the oculoplastics. A for antibiotics, and the antibiotics of choice will be the azithromycin, and erythromycin also can be used, and the tetracycline. So any of those antibiotics can be used to control the acute attack or acute trachoma, where there is acute follicular conjunctivitis and the mucopurulent discharge. F for facial hygiene. So proper washing of the face will prevent the auto-inoculation and prevent the transmission of infection from one patient to other, as also the flies can come on those secretions and on facial secretions and transmit the organism from one patient to another. So facial cleanness will be also a very important method for management. And the environmental cleanness to prevent sanitation services. Also, this will be very essential for eradication of trachoma or for control of trachoma infection. Okay, so this will be the management of trachoma. You will find that there are some historical tables about the grading of trachomas, and they are no longer used. Another disease, which is caused also by chlamydia trachomatis, but with different spectrum or different serotypes of chlamydia trachomatis, is the adult inclusion conjunctivitis. Adult inclusion conjunctivitis is caused by chlamydia trachomatis serotype D to K. So remember, serotypes A to C or ABC causing trachoma. Chlamydia trachomatis serotypes D to K causing adult inclusion conjunctivitis. The third serotypes of chlamydia, let me mention it also to you, maybe you'll be asked about it, which is L1, 2, and 3, which is causing non-ocular disease. It's called lymphogranuloma venereum. Lymphogranuloma venereum, it is a disease caused by chlamydia trachomatis, serotypes L1, 2, and 3. So what will be the incidence? It is called the adult, so it will affect the adults. It is a sexually, not a sexually transmitted disease, but it is related to sexual activities. So it will be affecting 5 to 20% of sexually active adults. This is L. In the Western countries. So how it is transmitted? It is transmitted by auto-inoculation from genital secretions, and also eye-to-eye transmission can occur, but it is less common. Like around 10% only of cases will have eye-to-eye transmission. So what will be the clinical picture? Those patients will have chlamydial infection. Originally, they have chlamydial infection in the genital tract. So in the males, it can cause some clinical pictures, and also in females can cause some clinical picture. So in urogenital infection, the original infection that will cause them the chlamydial infection, in males, it will be the commonest cause of non-specific urethritis or non-gonococcal urethritis. It is the chlamydia. So by far, it is the commonest cause of non-gonococcal urethritis is the chlamydia. So it's very common. It will cause urethritis, and this urethritis will cause dysuria and discharge. This will also cause epididymitis, and it is a trigger for Reiter syndrome. So in Reiter syndrome, there will be like what's called the cross reactivity. Like when the patient has a chlamydial infection or chlamydial urethritis, there will be antibodies that will be released from his body to fight against this infection. This antibodies has cross reactivity to the conjunctival tissue and uveal tissue in the eye. So it will cause uveitis, it will cause conjunctivitis and the keratitis, and also it will also has a cross reactivity to some of the joint tissues, so it will cause affection of the joints. This is called the Reiter syndrome. It is urethritis, it is joint affection, and also keratoconjunctivitis and uveitis. So the trigger will be the chlamydia, but it is not caused by the chlamydia itself. It will be caused by the autoantibodies that will cross-react between the chlamydial antigen and other body tissues like the joints and the eye. In females, it can cause dysuria, discharge, pelvic inflammatory disease. So this will be the initial presentation. So if you are suspecting a patient with adult inclusion conjunctivitis by clinical, just ask him about these manifestations. Regarding the eye itself, there will be conjunctivitis. So there is subacute onset of unilateral or bilateral redness, watering, and discharge, the same like any case of conjunctivitis. There will be watery or mucopurulent discharge. So both can happen. This will also sometimes was asked previously in one of the ICU exams. So it was many fell in this trap. So as like a general concept, we know that in the watery will be like related to the viral infection rather than a bacterial infection. But in the adult inclusion conjunctivitis, the chlamydia can cause both, can cause watery or mucopurulent discharge. There will be periauricular lymphadenopathy, and if there is a follicular conjunctivitis, more common in the inferior fornix. The follicular conjunctivitis are more common in the inferior fornix. There is variable keratitis that can range from superficial punctated keratitis, perilimbal subepithelial infiltrates, as I'm pointing to right now. There are some subepithelial infiltrates, conjunctival scarring, and pannus formation. So again, it is one of the diseases that will cause keratoconjunctivitis, affection of the conjunctiva and affection of the cornea. Investigations are not needed, but if you are in doubt, you can do tarsal conjunctival scraping, PCR, GEMSA stain, direct immunofluorescence, enzyme immunoassay, swab for bacterial culture, and culture on McCoy medium, which is very specific for the chlamydia. Treatment will be the same as acute conjunctivitis. First of all, you need to refer to this patient to a genitourinary specialist so that he will manage the underlying systemic condition of urethritis. Systemic therapy for any case of chlamydia will be like azithromycin. So this can be receiving one dose one day, and 1 week later we'll receive another dose. This will be enough and will be the most effective for patients with adult inclusion conjunctivitis, or they can receive erythromycin or tetracycline. And also, abstinence of sexual activities should be done, but to reduce the risk of transmission. And one of the important things or lines of management is treatment of sexual partner. I was asked about that specifically in my FRCS3 exam. So when I was in the exam, the examiner asked me everything about that, and he wants me, he just keeps asks me till I said it is we should do treatment of the sexual partner. He wanted to hear that specifically, so that if you are just treating this patient without treating the sexual partner, he will be reinfected again and again and again. So what are you doing is you are just losing your time, and the patient also is losing his time with ineffective plan of management. Okay. Okay, so this will be other two reasons for follicular conjunctivitis. The last cause of follicular conjunctivitis will be what's called the toxic medicamentosa. It was found that there are some drugs that will cause irritation to the conjunctiva, causing follicular conjunctivitis, namely the antivirals and the atropine, apraclonidine, brimonidine, neomycin. So again, these drugs can be asked in the exams, telling you which one of those drugs are more commonly to cause toxic medicamentosa or toxic follicular reaction. So remember those drugs. Mainly, it is the atropine, anti-glucomatous medications, and antiviral. Okay, so to summarize what we have mentioned, we have the giant conjunctival papillae. It has three differential diagnoses, mainly vernal atopic giant papillary conjunctivitis. For the vernal disease, it is of early onset, usually resolved by puberty, associated with atopic dermatitis. Sometimes family history of atopy, couple-stone papillae, Horner Taranta dots, shield ulcer, pseudomembrane, increased histamine in the immunoglobulin and in tears can show these giant papillae, can show these limbal nodules or Horner Taranta dots, and that shield ulcer. For atopic keratoconjunctivitis, is more common between 30 to 50 years old, and it's associated with atopic dermatitis, dermatitis of the eyelids, symblepharon papillae in the inferior fornix. And you can see that the affection of the atopic dermatitis, the maceration of the skin, the symblepharon, and the subconjunctival hemorrhage. Giant papillary conjunctivitis can occur due to allergy to foreign bodies such as contact lens, exposed stitch, ocular prosthesis, and scleral buckle, characterized by giant papillae like that. For the conjunctival follicles, it can be caused by three viruses like adenovirus, characterized by either epidemic keratoconjunctivitis, serotypes 8, 19, 37, with low systemic problems and more keratitis, preauricular lymphadenopathy, pseudomembrane, subconjunctival hemorrhage, pharyngeoconjunctival fever like 3 to 7, which characterized by more systemic problems as fever and pharyngitis, and less incidence of keratitis, only 30%. And it's very important for those patients to control the risk factors or to do proper hand washing, hygiene, prevent touching of the eyes, not sharing the towels, not shaking the hands, washing the equipments or any tools that the patient is using. So some sanitation or sanitary measures are very essential here. Characterized by follicular conjunctivitis and the subepithelial infiltrates, which is the corneal affection. Regarding the molluscum contagiosum, it is characterized by presence of lead mass, waxy pale, umbilicated lead nodule, which will shed the virus, which is the pox virus, into the conjunctiva, causing follicular conjunctivitis. And if severe, we consider the HIV infection. This is the molluscum contagiosum. For the herpes simplex, it is a disease of childhood, as it is primary herpes infection causing blepharoconjunctivitis with or without lead vesicles, with or without keratitis, and associated with preauricular lymphadenopathy. You can see this is the blepharoconjunctivitis, and also can be associated with follicular conjunctivitis. Other diseases will cause conjunctival follicles are adult inclusion conjunctivitis. It's caused by Chlamydia trachomatis serotypes D to K associated with urethritis, characterized by presence of bulbar follicle subepithelial infiltrates as corneal infection, treated by doxycycline, erythromycin, azithromycin, and treatment of the sexual partner. Trachoma caused by Chlamydia trachomatis serotypes A to C, characterized by both papillary reaction and conjunctival follicles, with conjunctival scarring causing what's called Ehrlich's line, limbal follicles or Herpes spets, entropion and trichiasis, and the superior corneal pannus and the corneal scarring. For toxic drugs, some drugs can cause toxicity to the cornea, like follicular conjunctivitis, such as antivirals, atropine, apraconidine, brimonidine, and neomycin. Finally, some other important differential diagnoses that I'm going to share with you now, so that if you are presenting in the exam or if a real case, you know how to think of a case of conjunctivitis. So we said if you have a patient with large papillae, like more than 1 millimeter, you are considering a giant papillary conjunctivitis, like vernal keratoconjunctivitis or atopic keratoconjunctivitis or giant papillary conjunctivitis. If you have a patient with acute follicular conjunctivitis, you consider adenoviral keratoconjunctivitis, molluscum contagiosum, primary herpes simplex, chlamydia, and toxic medicamentosa. For patients with chronic follicular conjunctivitis, you consider what is called the Parinode oculoglandular syndrome, molluscum contagiosum, primary herpes simplex virus, chlamydia, and toxic medicamentosa. For conjunctivitis with preauricular lymphadenopathy, consider epidemic keratoconjunctivitis, herpes simplex virus, gonococci, chlamydia, and Parinode oculoglandular syndrome. For membranous conjunctivitis, consider diphtheria, gonococci, beta hemolytic streptococci, Stevens-Johnson syndrome. And for pseudomembranous conjunctivitis, consider epidemic keratoconjunctivitis and pharyngeoconjunctival fever, primary herpes simplex virus, bacterial, chlamydial, vernal keratoconjunctivitis, chemical burn, OCP, and lignous conjunctivitis. And the lignous conjunctivitis with other conjunctival diseases with pathological importance will be discussed in the pathology lecture. So regarding the ICU exam, there is a certain section for pathology where most of the pathological diseases like lignous conjunctivitis, corneal dystrophies, tumors or conjunctival tumors, retinal tumors, choroidal tumors, they are asked specifically in this section. So this section will be after we clear the cornea and lens and oculoplastics. So we will discuss these. We will collect a lecture for all pathological conditions. So this is for now for the conjunctival diseases. I hope that this is clear. If you have any questions, please let me know before we start the corneal disease. Okay, fantastic. Let's now start with the cornea. So the cornea, when you take a slit of the cornea, you will find that the cornea is divided into these layers, starting by the epithelium, then the Bowman's layer, then 90% of the cornea is made by the stroma, then the Descemet's membrane, and the dual layer and endothelium. The diseases of the cornea range in this spectrum. So there are congenital diseases, which we already covered in the pediatric ophthalmology. Like in 1 hour, we covered all the corneal congenital disorders, traumatic conditions affecting the cornea, inflammatory conditions such as keratitis, ectasia such as keratoconus, the keratoglobus, and pellucid marginal degenerations, and the important 2Ds, which are dystrophies and degenerations. Dystrophies and degenerations will be covered in the pathology. They are of pathological importance, and the congenital was covered in the pediatric ophthalmology. So we will cover the trauma, inflammatory ectasia, and of course the surgery at the end. Okay, but of course this will not be today. It will not be unlikely to be completed today. So we will mostly to cover today the trauma and inflammation, and for the ectasia and surgery maybe for the next time. Okay, so for the congenital, to just a quick recap of what we mentioned in the pediatric ophthalmology, we said that the congenital corneal affection can be in the form of limbal dermoid and some tears in the descemet membrane, as in Habeas stria, the megalocornea, the microcornea, the posterior keratoconus, and the sclerocornea. So collectively, we have the stumped differential diagnosis. You may refer to that in the pediatric ophthalmology lecture. Okay, so regarding the trauma, what are the kinds of trauma that those patients may or the corneal affection may cause? Those patients can have corneal abrasion, which is simply sloughing of the epithelium. Do you hear my voice clear? Dr. Sherry, I didn't do anything unusual, like I didn't even move 1 millimeter. I'm still in the same place, in the same position. Okay, so back to the corneal abrasion. So if a patient has a corneal abrasion, can be done by mechanical, like trauma, or can be done by contact lens if a patient is contact lens wearer. So this will be causing a sloughing of the epithelium, leading to epithelial defect that will stain positive by the fluorescein. And also there will be those patients who are contact lens wearer, or those patients who are having a history of trauma, don't patch those eyes. Don't patch those eyes. You need to so that these scenarios already represent a high risk of infectious keratitis if patches. So, and also no patching is necessary if the abrasion is less than 10 millimeter. So actually, so what is the use of patching in case of sloughing of the epithelium? This is just to prevent the rubbing of the eyelid against the cornea, so that it will promote the epithelialization. But this is not very essential or not very important for small abrasions like that. So if the exam asks you about if we have a small abrasion like that, it is caused by contact lens wearer or by trauma, and should you patch? No, you shouldn't patch. So the mode of treatment will be one thing to say if we need to patch or not. Second thing is the size of the lesion or size of the epithelial defect. So if it is less than 10 millimeter, like that, it is like around 3 to 4 millimeter. So no need for patching. Also, corneal abrasion can be circular with epithelial defect or can be linear like that. And in this linear, no need for doing anything, like just the lubricants and the antibiotic cover will be enough. So this will be not very important for the exam, but what is the most important is the chemical burn. In the chemical burn, we have two forms of the chemical burn. It can be an alkali burn or it can be an acid burn. So what is the differences between both of them and how to manage? This is what we are going to see right now. So Dr. Alia is saying that vitamin A is good as well. Yes, Dr. Alia, I agree with you. So regarding the differences between the chemical burn, the alkali tend to be more severe. It tends to penetrate more. So this is very important. The acids are less severe. So why the alkalis are more severe? Because they tend to penetrate the eye more rapidly. In less than 1 minute, the whole cornea will be denaturated. They will combine with lipids, mucopolysaccharides, collagen, leading to disturbance or disruption of cells and necrosis of the tissues. So on ocular surface, they spolify cell membranes, intracellular bridges, which facilitates rapid penetration into the deeper tissue, into the aqueous and vitreous. And since that they will cause more incidence of necrosis, they will necrose also the blood vessels. So they will necrose the conjunctival blood vessels, causing what's called the cook de fish eye appearance. the cornea appears white and chalky and opaque. So here is one tricky question in the exam. They bring you a picture of a patient with white eye of a chemical burn and asks you if this is carry a good prognosis or poor prognosis. So you see that there is no inflammation, the eye looks white and everything looks good. So it's a good prognosis. Actually, no. The absence of vascularization or the whitish cornea is a poor prognosis. It's a poor sign. Together to add with the absence of limbal stem cells, as we are going to discuss right now. So alkali is more severe, characterized by what's called the cocked fish appearance. Whitish cornea, there is less intense inflammation of the conjunctiva, maybe whitish in color. So this will be a sign of alkali burn. On the other hand, the acid burn, the acid will cause denaturation of protein in the central cornea, forming precipitates. These precipitates will retard the additional penetration. So the acid will prevent its own spread by the precipitations that it will form. So this localized damage effect due to the coagulation effect and the protein precipitates, leading to such physical barrier. So here the most important question is, what is more common to be more penetration? The alkali causing more penetration. Okay. Okay, so this was just okay. Other signs of trauma, it can be a corneal foreign body like that, and the corneal foreign body can be characterized by impact of the foreign body and surrounded by what's called rust. So it can be surrounded by edema and surrounded by rust, and it can be either partial thickness or full thickness. So the importance here is to detect whether the corneal wound or the corneal foreign body is partial thickness or full thickness. If it's a partial thickness, it can be removed under a slit lamp and to remove the foreign body and the surrounded rust. But if it is full thickness, this means that the globe is open. So it needs to be managed in the operation room. For example, like this is a corneal laceration. It can be associated with a foreign body or without a foreign body. How to check? This is an emergency. Those patients need to be admitted to the surgery in order to reposit this prolapsed iris and to close this defect to prevent the endophthalmitis. So how can we check, or how can we make sure that those patients have open globe? This can be done by what's called the Seidel test. So Seidel test is a test done to rule out an open globe by just putting a concentrated fluorescein to cover the suspected leakage site. And you see this green river sign or fountain sign, like you can see a leakage coming from the area of the opening or of the break, leading to like a green river. So this is a positive sign, or what's called a positive Seidel test, meaning that there is a perforation of the globe here. So those patients should be again admitted to the OR, should receive topical antibiotics, or say it is advocated by some, but some say they should only receive systemic antibiotics with a follow-up or with admission to the OR, to either and until admission of the patient to OR, you receive patching or bandage contact lens as needed. And we need to do CT scan in order to detect if the presence of any intraorbital or any intraocular foreign body. But if it is, we can also consider MRI, but MRI is contraindicated if the foreign body is metallic. Okay, so this is just a quick overview of this foreign body. I just put this slide a little bit later, but we will continue our discussion in patients with chemical burn. So how to manage the patients with chemical burn? This will depend on what is the stage of this patient, and what is the state of the cornea, and what is the state of the conjunctiva. And by the state of the cornea, we need to know if the cornea has, see this epithelial defect, the cornea has almost a subtotal epithelial defect with whitening of the whitening of the limbus, whitening of the cornea, like around 6 o'clock hours, and conjunctival hyperemia over the other 6 o'clock hours. So this patient has an acute attack or acute stage. This patient is presenting acutely in the few days after the chemical burn. But you can see this patient has more quiet eye, and there is conjunctivalization and cicatrization of the cornea. So this means that this patient has chronic case, or it's a chronic chemical burn. So how can we treat these patients? Those patients are an emergency. Those patients, how we need to have a stepwise management in order to preserve the eye, because this patient has one of the serious ophthalmic emergencies. So how can we manage? Step one, if the patient is coming in the acute phase, we need to do copious irrigation with fluids, immediate copious irrigation with whatever you have, like sterile water, like saline, like Ringer solution. And you need to measure the pH before and after the irrigation, as you want the pH to be neutralized. So you measure the pH before, you find it is alkaline, it is acidic. Do irrigation as much as possible, and then you will measure the pH until the pH is neutralized. Also, this will be the first thing to be done. Then you remove any chemical particle under the surface, from the surface of the eye, and invert the lid to remove it from the fornix by just a sterile cotton swab. And so you measure the pH, then remove the foreign body if they are present. And then after this will be your duty in the clinic. What you do in the emergency, you irrigate, measure the pH, remove the foreign body, then you assess the situation as we are going to discuss right now, and now give the treatment. What will be the treatment? Many treatment. Artificial tears for lubrication, topical antibiotics to guard against the secondary infection, topical cycloplegics to relieve the spasm and to relieve the pain, oral doxycycline, as the oral doxycycline, not for its antibiotic characters, but it is for anti-proteolytic. Like this will be the cyclosporin, sorry, the doxycycline or the tetracycline has an anti-proteolytic or anti-collagenase effect. So it will antagonize the lysis of the cornea and prevent or delay the melting of the corneal tissue. Vitamin A for the corneal epithelium, vitamin C for the corneal stroma. Topical steroids will decrease the inflammation. It will sound that, although that you can see, or you can argue that the topical steroids can increase the melting and increase, so but actually yes, it can be correct, but for those patients we have more concern, or more important concern, which is the severe inflammation. So we need to quieten the severe inflammation by the steroids, can be given for 1 to 2 weeks, then with gradual tapering. So as we see, the epithelium is healing and then the inflammation is quietened, we can taper the steroid after the first week. Control the intraocular pressure by anti-glaucomatous medications, because of the inflammation also can cause uveitis and the glaucoma. And the contact lens to aid the healing of the ulcer. So this will be for the acute phase. This can be done for like 1 week, 2 weeks, 3 weeks, until the eye quieten, and then we need to manage the complications. So the complications will be like symblepharon. So we can go for a surgery to do symblepharon lysis, or there is a absence of the conjunctival tissue. We can do conjunctival transplantation from the other eye, or if it is bilateral, we can do amniotic membrane graft. Also, we can do tarsorrhaphy if there is persistent epithelial defect that is not healing, so we can go for tarsorrhaphy. This is for complications. Step 5 is for visual rehabilitation. So for visual rehabilitation, we have epithelial defect. that can be due to limbal stem cell deficiency. So the chemical injury will cause limbal stem cell loss. So we need to assess the limbal stem cells to check how much loss is the limbal stem cells is present. And if there is limbal stem cell loss, we do limbal stem cell grafting or limbal stem cell transplantation from the other eye or from a relative to the patient if he has a bilateral disease, so that we are preparing the ocular surface for the next surgery, which is the penetrating keratoplasty. So penetrating keratoplasty, if it is done without stem cell, without healthy bed, it will fail. So we do limbal stem cell first, then penetrating keratoplasty in another setting. If both are failing, or if the case is very severe and no good prognosis of limbal stem cell transplant or PKP, so we can do what's called keratoprothesis. Keratoprothesis, okay? So how can we assess the condition? Like how do we assess the limbal stem cell conditions and the corneal condition? There are two classifications. One is called the Rober-Hall classification. The Rober-Hall classification is classifying the prognosis according to the clinical appearance of the cornea and the degree of limbal ischemia. So it is called grade 1 if it is clear cornea with no limbal ischemia, so it has a good prognosis. Grade 2, a patient with hazy cornea and the iris details visible, so I can see the iris below the cornea, so we do less than, and there is less than 1/3 limbal ischemia, so it has a good prognosis. Opaque cornea, there is iris vessels obscured, like there is 1/3 to 1/2 of limbal ischemia, so there will be good prognosis. In grade 4, the opaque cornea, there will be iris vessels obscured, so we can, with more than half or 6 o'clock hours limbal ischemia, this is a poor prognosis. This table from the Oxford Handbook of Ophthalmology. Okay, the next classification is by DOA. It's called DOA classification, in which it classifies the prognosis into according to the limbal clock hour involvement and also the conjunctival involvement. So grade 1, there is no limbal involvement, but there is no conjunctival involvement, so it has a very good prognosis. For grade 2, it has less than 3 clock hours of limbal involvement with less than 30% of conjunctival involvement. It has a good prognosis. Between 3 to or more than 3 but less than 6 o'clock hours of limbal involvement with between 30 to 50% of conjunctival involvement, it has a good prognosis. 6 to 9 limbal hours, 50% to 75% conjunctival involvement, it has a good or guard prognosis. More than 9 to 12 or subtotal limbal involvement with subtotal conjunctival involvement, it has a guarded to poor, with total limbal and conjunctival involvement will be characterized by very poor prognosis. Okay. Dr. Selma, how do you usually manage the corneal neovascularization? Okay, so the corneal neovascularization, well, it depends on its level, whether it is superficial or deep, and there are several measures to do with it. First of all, we can do subconjunctival anti-VEGF pre-operative. So we do subconjunctival anti-VEGF, inject perilimbal in the upper half and in lower half, and wait for the spontaneous improvement of the neovascularization. This is, I have some cases that show very fantastic regression, especially in patients with deep anterior lamellar keratoplasty, where the blood vessels are going in the interface between the graft, the recipient graft, and the donor's graft. Also, other measures, we can do the argon laser photocoagulation. So pre-operatively, we can do argon laser session where we are selectively burn the blood vessels pre-operatively. So we target the blood vessels on the argon laser machine and do these burns. Other methods, intraoperatively, we can do either cautery. So by electrocautery, we cauterize the blood vessels. And the other method, so the previous three methods, like the electrocautery, the argon photocoagulation, and the subconjunctival anti-VEGF, all these can, the main problem is the recurrence. So it will recur. Yes, that's what I'm telling you right now. It will recur. The only thing that will make the blood vessel will not recur, but it is not very useful for all cases, is the ligation. You do ligation, suture ligation to the blood vessel. But this will be unlikely that you can do this unless you have very few and very large blood vessels. So if there are few blood vessels and large blood vessels, you can just ligate them with a suture preoperatively. You're welcome. Okay, ready for the infectious keratitis? So this will be the main topic. I'm afraid that what do you think if we stop at that level right now? Because actually I have like another webinar after 25 minutes. It is not like a course, but it will be like a webinar for our club journal at our department. So we need, actually they give me some assignments, like some papers to read and discuss, and I haven't even read them. So, okay, we will stop like that at that level, because even I want you to be on fully concentrated for the infectious keratitis. It will be the core topic for the cornea, so I need your undivided attention. Okay, thank you very much. Did you enjoy the lecture? Is it easy? I think that is much easier than the pediatric ophthalmology and strabismus. Do you agree with me? Okay, so I told you that earlier. I actually don't commit myself very much to the table that is present in the timetable that I said. As I told you, if I find that I need more lectures, I will give you more lectures. So don't worry. I will give the cornea the time that it needs, and for other topics and for other sections as well. Okay, thank you very much. See you soon next time. Non-steroidal and steroids have a role in new vascularization of the cornea. They will have a role depending on the pathology. You see, it will not cause regression of the new vessels, but it will control the underlying pathology that will cause the new vessels. So it will, you make it doesn't worse more. Dr. Yahya, how can I contact you with you? Please, I am already in the group. You will find my number in the group. Okay, any question? Okay, you're welcome. Thank you very much for your attention, and see you soon in the next time.